didn't hear this, sir.
Okay, in this first session after formal inauguration, the task which has been given to me is to talk about SGLT2 inhibitors, incretins and glitazones in coronary artery disease in diabetes. Now, since we, as Dr. Ashutosh and others pointed out, that our task is to help humanity. And whenever we talk of diabetes, though this slide, most of you would have seen, anyone who delivers any talk about diabetes talks about legacy effect. And it is known to most of us. But I still bring it here because we cannot overemphasize it. This is the problem with our country, that with the patients also and to some extent physicians also, some kind of clinical inertia. We don't hit early, we don't hit hard, we don't control sugars very well in the first few years of diagnosis, and then patient comes at the age of 40 when he has already had diabetes for 10 years with microalbuminuria and with non-proliferative retinopathy, and then we start controlling, and then we get frustrated that we are controlling but still we are not preventing a heart attack. So this is something which we should clearly take it as physicians. It's our duty. It's not just our something which we should do. It is our duty that we should tell the patient that he has to control sugars very strictly in the first few years of diagnosis, because that is going to pay him for the rest of his life. We have data till 30 to 40 years now from UKPDS. So it is very important that we control sugars very early and very strictly initially, and that will go a long way in preventing cardiovascular disease in this country. Now, but how we control, does that matter? Do different anti-diabetic effects have different agents have different effects on heart? Now we'll take one by one. We'll not talk about sulfonylureas and metformin because that is not the topic. So we'll only talk about things which I am supposed to speak on. And the first we start with DPP4 inhibitors. Now DPP4 inhibitors have been there for almost a decade, and we have used them, and we know that they are efficacious. They lower blood glucose effectively. They have some other effects. They are weight neutral, and they may have possibly cardiovascular benefits because there is some experimental evidence that they help in ischemic injury. They have benefits on inflammatory pathways. So there is rationale that they could be good for the heart. But first of all, we need to see whether they are safe for the heart. So so in this talk, I will basically be talking about cardiovascular outcome trials. So there will be a lot of trials and epidemiology. So this was the first trial of DPP4 inhibitors, first major cardiovascular trial, outcome trial of DPP4 inhibitors, which was published. The SAVOR-TIMI trial on saxagliptin, which was an elegantly conducted trial, more than 16,000 patients with type 2 diabetes who were at a very high risk, who had either a history of cardiovascular event or who were at risk for cardiovascular events. And they were randomized to receive saxagliptin or placebo, followed for 2 years. And this is what was found, that the hazard ratio was 1. So there was no effect of the drug on the cardiovascular outcomes. Similarly, on secondary outcomes as well as on other outcomes. But importantly, as we are all aware, that the hospitalization for heart failure was increased in patients who received saxagliptin. So the trial concluded that saxagliptin did not increase or decrease the rate of ischemic events, though the rate of hospitalization for heart failure was increased. Although saxagliptin improves glycemic control, other approaches are necessary to reduce cardiovascular risk in patients with diabetes. So this was about saxagliptin. Similarly, similar trial called TACOS was conducted with sitagliptin. Again, a randomized trial, about 15,000 patients and median follow-up of 3 years. And again, it was found that there was no difference in primary cardiovascular outcome in patients who received sitagliptin compared to placebo. And also in this trial, there was no increased risk of hospitalization for heart failure. So sitagliptin did not show an increase in heart failure, at least in this trial. And the overall mortality was also not different in patients who received sitagliptin. So it was concluded that in patients who have established cardiovascular disease, so these patients already had cardiovascular disease, and adding sitagliptin to usual care did not appear to increase the risk of major cardiovascular events, hospitalization, or for heart failure or other adverse events. Then there was a trial called Examine on allogliptin. Allogliptin is not available in our country, but it is used elsewhere, and similar results were found that it did not increase the risk of cardiovascular events, but there was a little increase in the risk of heart failure. Now, linagliptin, we don't have the results of cardiovascular outcome trial, but what we have is meta-analysis. At least in that, there is no increase in the risk of cardiovascular events. And vildagliptin, which we use commonly, again, meta-analysis, there is no large-scale cardiovascular outcome trial planned for vildagliptin, simply because it is not, they have not applied for approval in US, and so they are not bound by any FDA regulations. But whatever meta-analysis we have, it does not seem to increase the risk of cardiovascular events. So DPP-4 inhibitors, we feel that they are safe for patients with coronary artery disease. Only caution is hospitalization for heart failure. So it is recommended that any patient who is at high risk for heart failure or who has heart failure should not receive at least saxagliptin. And then you need to decide based on the further data if we get. Now coming to the other incretins, the GLP-1 analogs, they are promising drugs. They have the benefit of causing significant weight loss. They also have favorable effect on lipids. They also lower the blood pressure somewhat, and that is why they could be interesting to study as far as cardiovascular outcomes are concerned. Now the first trial in this was on lixisenatide, in which there were 6,000 patients with diabetes who had myocardial infarction or unstable angina in the previous 6 months, and they were randomized to lixisenatide or placebo, and the median follow-up was about 2 years, and it was found that there was no increase in the risk of cardiovascular events. It was almost similar. So in patients with type 2 diabetes and recent acute coronary syndrome, the addition of lixisenatide to usual care did not alter the rate of major cardiovascular events or other serious adverse events. Now, recently, last year, few months back, we had LEADER trial on liraglutide. Liraglutide we have in this country, and about 9,000 patients with type 2 diabetes and high cardiovascular risk. And this high cardiovascular risk was either they had established vascular disease or at least one CV risk factor, which included any amputation or carotid artery stenosis or a low ankle brachial index, and in those patients who were more than 60 years, and they were randomized to receive liraglutide or placebo, followed up for about 4 years. And this was interesting that liraglutide showed benefit. It showed benefit in terms of cardiovascular outcomes. The hazard ratio was 0.87, so 13% reduction in primary outcome, which was the first occurrence of cardiovascular death, non-fatal myocardial infarction or non-fatal stroke. Also, the death from cardiovascular causes was also reduced significantly by liraglutide compared to placebo. So they concluded that the rate of first occurrence of death from cardiovascular causes, non-fatal MI or non-fatal stroke among patients with type 2 diabetes was lower with liraglutide than with placebo. But then later on it was found there was some problem with the trial. Patients who were in placebo were receiving higher doses of sulfonylureas and insulin and had higher rate of severe hypoglycemia, and that could have contributed to higher rate of cardiovascular adverse events. So we are still awaiting any further data on maybe some other GLP-1 analogs, but there is some evidence that it could be beneficial. Now coming to the newest drugs which have been there now for some time, for at least 2 to 3 years, the SGLT2 inhibitors. Now this is the trial which was published about a year back, no more than a year back, and this has changed a lot. This is called EMPA-REG outcome, the empagliflozin study. And again, a very nicely conducted study. More than 7,000 patients with established cardiovascular disease randomized to either empagliflozin 10 mg, 25 mg or placebo, and followed up for 3.1 years. And this is what was found, that there was significant reduction in the primary outcome, which was a composite of death from cardiovascular causes, non-fatal MI or non-fatal stroke. So 14% reduction in the primary outcome. 32% reduction in all-cause mortality and 38% reduction in cardiovascular mortality. So this was highly significant. Till date, we had no drug which caused, no anti-diabetic drug which was leading to this kind of benefit. This was almost equivalent to statins. So this is what we found. And the hospitalization for heart failure was also significantly reduced. Though the secondary outcomes, when they were studied, none of them were significant independently. That was mainly because of smaller numbers of events. So it was concluded that patients with type 2 diabetes at high risk for cardiovascular events who received empagliflozin as compared to placebo had a lower rate of the primary composite cardiovascular outcome and of death from any cause when the study drug was added to standard care. So all these patients were getting standard care, statins, BP control, glycemic control, everything. Similar trials are undergoing for other SGLT2 inhibitors, dapagliflozin and canagliflozin. The results are expected in next couple of years, but whatever pooled results from pooled data is there, that seems to be at least not harmful. Now coming to thiazolidinediones, so we have gone back now to the older drugs. Now thiazolidinediones, I'll start with a drug which is not available currently, rosiglitazone, but we have used it earlier, and it all started with a meta-analysis by a gentleman called Nissen in 2007, in which he did a meta-analysis of 42 trials on rosiglitazone and assessed the risk of myocardial infarction. And this is what he reported, that if they took all the trials together, the myocardial infarction was significantly increased, the death from cardiovascular causes was significantly increased when they used rosiglitazone. And when they compared with other drugs, it was significantly increased. But there were some problems highlighted. So based on this, FDA issued a box warning that it should not be, one should be cautious, and it was withdrawn from India. But then there were some problems with the meta-analysis, that original source data could not be accessed. Trials were not designed to assess CVD outcomes, so they were just usual data. And the adverse events were very small, and if you see, the confidence intervals were very wide, 1 to 2.5. So it was very difficult to conclude anything. So then came another study called RECORD study. So about 5,000 patients randomized to rosiglitazone plus either metformin or sulfonylurea or an active control. And median follow-up was 5.5 years. And this is what was found, that there was no increase in any adverse cardiovascular events except heart failure, which we are all aware that thiazolidinediones by increasing fluid retention can increase heart failure. So that is not a dispute. But it did not increase any other adverse cardiovascular events. But then this trial was also criticized. Patients who were on rosiglitazone had received more statins. So they said that could have influenced the outcomes in favor of rosiglitazone. But then this FDA ordered a re-education of the record. The data was analyzed again, taking into account everything. Still they found that there was no increase in the risk of adverse cardiovascular events. Now coming to pioglitazone, which we are using, and we have with us and we are using. So the proactive study, not a recent study, it has been some time that we know about it. So about 5,000 patients who had evidence of macrovascular disease assigned to pioglitazone or placebo. and follow-up average was about 34 months. And this is what was found, that pioglitazone improved cardiovascular outcomes, cardiovascular mortality, and also other cardiovascular outcomes, which was significant. So this was concluded that the composite of all-cause mortality, non-fatal myocardial infarction and stroke in patients with type 2 diabetes who have a high risk of muscular events was reduced by pioglitazone. So what do we conclude? So I think just three or four messages. As I emphasized in the beginning, that good glycemic control soon after diagnosis of diabetes is important in reducing long-term cardiovascular complications. DPP-4 inhibitors appear to be safe for heart and may in fact have some beneficial effect. However, there are some concerns about increased risk of heart failure, especially with saxagliptin. GLP-1 analogs appear to be safe for heart, and liraglutide has shown cardiovascular benefit. SGLT2 inhibitors are safe for heart, and recent results about cardiovascular benefit with empagliflozin are very reassuring. And pioglitazone shows evidence of cardiovascular benefit. However, caution is needed because of increased risk of heart failure and because you have other drugs which are available. So one should use it, but with caution.
So your personal experience with these drugs?
With SGLT2? Yeah, we have used SGLT2. In fact, we have been using them since they came. We have used all three. And yeah, we have found very good response in terms of glycemic control, in terms of discontinuation of other drugs, the reduction of insulin dose, body weight, cardiac outcomes I can't comment in a clinical setting, but the time period is too short. But yes, we have had adverse effects. We have had, as reported, we have had urogenital infections. We have had ketosis also. In fact, we reported 3 cases of ketosis with SGLT2 inhibitors. But most of these were not serious ketoacidosis. They were just, and they were actually wrongly used. They were not prescribed by us. They were prescribed elsewhere in patients who probably did not need, patients who were markedly insulinopenic, in which patients who were undergoing surgery. So those patients, we saw 3 cases. But overall, in terms of efficacy, weight loss, they are really promising. They have shown.
You say they are tailor-made for obese diabetics?
Yeah, kind of. We can say that the extent of weight loss which is seen with SGLT2 inhibitors is, in fact, almost same or maybe more than even GLP-1 analogs. So yes, they are a real boon for obese diabetics. Sure.
Dr. Gupta, I have 2 questions for you. The first one is that a few years ago, pioglitazone was withdrawn in India and then it came back.
Yeah.
There were fears of bladder cancer. How far is it true? The other question is that, is there any increased risk of bone fracture?
Yeah, there is definitely increased risk of bone fracture, but that is confined to women, postmenopausal women. So even in proactive, there was, even with rosiglitazone, even in record, they had increased risk of fracture. So that is very much there. So I would probably avoid in postmenopausal women. Now regarding bladder cancer, the last word is yet to be said. It's not settled. There was some evidence, there was some suggestion of a dose response kind of or a cumulative dose kind of a thing, but nothing conclusive can be said. But yes, we cannot discount the possibility that it can cause bladder cancer. Sure.
Dr. Gupta, I have just one very common problem that we are facing with the SGLT2 inhibitor. That's UTI.
Yes.
And especially in Indian context, where probably the hygienic conditions are not very good, probably we are getting more and more cases of UTI. So, what is your experience in this regard?
Yeah.
The second thing that about pioglitazone, the 2 very important feature of pioglitazone is one of the best insulin sensitizer. And the second thing is it is lipid friendly also.
Yeah.
So this should be used, especially in mild to moderate cases of diabetes. It can be used where we are not at all any risk of heart failure. I think this can be
True.
very well used.
Agree. Now about SGLT2 inhibitors and urine infections, what we see more commonly than urine infection is genital infection, belinoposthitis and vaginitis. Now in most of the patients we are able to treat that infection by simple antifungals or something, maybe topical and oral antifungals, but yes, there is a discontinuation rate. There are some patients in whom we are not able to use. At the same time, we tried to analyze our data. We found it's about 5% patients would have significant belinoposthitis so as to need discontinuation. Otherwise, largely we are able to use these drugs. Hygiene we can instruct them, and one particular thing is this belinoposthitis of course does not occur in circumcised men, so that is where one can use it.
Up to what level of GFR we can use SGLT2 inhibitors in diabetic nephropathy patients?
Yeah, so SGLT2 inhibitors depend on glomerular filtration. So if the GFR is low, then they are not effective. So currently the recommendation is less than 50, we don't use it. It's a little different from DAPA and canagliflozin and empagliflozin, but roughly less than 50, it's better not to use it.
Do you use in patients with diabetic nephropathy, what is your experience of using SGLT2 inhibitors in patients with diabetic nephropathy?
You mean proteinuria?
Diabetic nephropathy and estimated GFR levels more than 50. Do you have any experience of using these drugs?
Yeah, we have used them. We have used in patients who have GFR more than 50. We do use it.
And what about the complications, whether it is effective or not, one, and the complications are different as compared to those patients who have got a normal eGFR levels more than 90?
We don't find any increased complications. See, complications actually, even in lower GFR, they apparently doesn't lead to much complications. The efficacy is less. That's the only thing.
And another question is, because of the fear of the bladder cancer, we stopped using pioglitazones for some time. So subsequently, the crisis was resolved by saying that the incidence of bladder cancer is as what we are getting in the normal population. You might have used pioglitazones. Almost everybody is using left and right in diabetic patients pioglitazones. What is your experience as far as the bladder cancer is concerned in these patients? One, and second is, how frequently should we really screen these patients for bladder cancer, and what should be the mode of screening for bladder cancer in these patients?
I have never seen a patient with bladder cancer who has been on pioglitazone. My teachers have not seen either.
That's why I asked the question.
So who have practiced diabetes for 40 years, they also say that they have not really seen. In fact, bladder cancer is somehow not that frequently seen in diabetes somehow. So I have not personally seen any patient who has been. In fact, now if I see a bladder cancer patient, first thing I ask is whether he has taken pioglitazone. But whatever little I have seen, I have not encountered that. Now, screening modality, I feel one thing is that routine screening for bladder cancer could be simply by a urine routine examination. I would feel if the patient has hematuria or something, then you can screen by other means, but to advocate a routine cystoscopy or a urine for cytology may not be warranted right now. But again, this is a limitation of our data, so we don't have sufficient data right now to recommend